Hello, dear students. Today we speak about non-carious lesions of the teeth and systemic and focal hyperplasia, flarosis, and hereditary dental malformations. Let's start. Classification of non-carious lesions. Of course, you should know about this classification. It is Groshnikov classification. First group, it is pathology of hard dental tissues that arose during the period of follicular development. First, it is hyperplasia of tooth enamel, hyperplasia of tooth enamel, flarosis of teeth, hereditary disorders of the development of hard dental tissues. Medicinal and toxic destruction of the development of dental tissues. Then, second group, it is pathology of hard tissues of teeth that arose after their eruption. Pathological abrasion of teeth, wedge-shaped teeth defects, erosion of the teeth, medicinal and toxic disorders of the development of dental tissues, tooth injury, necrosis of hard tissues of teeth, and hyperesthesia of dental hard tissues. Then, enamel hyperplasia. Of course, it is non-carious lesions of hard dental tissues that caused by various endogenous and exogenous factors. It is characterized by quantitative and qualitative changes in the structure and composition of enamel. Insufficient or delayed function of enameloblasts, that leads to development of enamel hyperplasia can be caused by metabolic disorders in the child's organisms in case of various diseases. Or it can be a result of disorders of formation of hard tissues in the supradental follicle caused by mechanical injury or infection. In case of enamel hyperplasia, both structure of protein matrix of enamel and its primary mineralization may be upset. So, systemic, we know about local hyperplasia or systemic hyperplasia. And diagnostic, of course, is time of appearance, localization of the lesions and symmetry of lesions, enamel gloss, sounding, vital staining, dynamics of changes, and dentoscopy with ultraviolet radiation. Then, local hyperplasia is more often detected in premolars of upper and lower jaws, more rarely in permanent incisors. One or two teeth get affected. Development of this form of hyperplasia is associated with a mechanical injury. Or with an inflammatory process in periodontium of a preceding deciduous tooth. Mild enamel lesions manifest in color change, you can see on the case. In case of more severe defects, the shape of tooth and the structure of its hard tissues undergo some changes. For example, it is Turner's teeth. Method of treatment depends on the level of hyperplasia severity. And spotted form of hyperplasia is not always striated. In case of cosmetic defect, hyperplastic lesion can be removed by preparation and filling with composite materials. Then, systemic enamel hyperplasia is characterized by affection of groups of teeth with simultaneous primary mineralization, and prevalence of systemic hyperplasia is 2–14%. First, permanent molar and incisors of upper and lower jaws are more frequently affected. Sometimes enamel hyperplasia develop as a result of childhood rhinitis, serious infection diseases, dyspepsia, and insufficiency of endocrine glands. Then, hyperplasia is observed in both permanent and deciduous teeth, but the latter occurs much more rarely. More often, hyperplasia occurs in permanent teeth, which can be explained by frequent diseases in children of the first year of the life. In case of systemic hyperplasia, the defects localize on symmetrically located teeth at the same crown segments with a lesion of similar shapes and sizes. Localization of hyperplastic enamel segments can tell the age when the child was sick. Diseases of the first 3 months of life into enamel defects is first molars only. Hyperplastic elements localized along the incisal edges or central and lateral incisors cups of the first molar, for example, cause disorders of mineralization at the age of 6-9 months. Then changes of enamel color manifest in the white spot with accurate limits and glossy surfaces of various shapes. The spot more often localize on vestibular surface of symmetrical teeth and they do not provoke any unpleasant sensations. Then enamel undevelopment in a more severe form of its hyperplasia, and clinically it manifests with wavy, dotted or furrowed enamel. The dotted form of systemic hyperplasia is the most frequently defined form in clinics. Enamel defects look like dotted hollows located on vestibular and lingual surfaces of dental crowns and at varying levels of various groups of teeth. Then we should know about children who have a history of. So look, please, that that the reasons of systemic hyperplasia, and write in your synopsis. Right after eruption, dental enamel is a holes in colored normally. Later it gets pigmented, but it is always dense, smooth and glossy. Sometimes the absence of enamel in some crown segments is revealed. Called aplasia. Caries frequently appears in the areas of hyperplastic defects of enamel. And diseases, they are transferred by a pregnant woman during the formation of the rudiments. I tell you previous slide that it can be 5-8 months of pregnancy, and cause systemic hyperplasia of the enamel of permanent teeth. And look please on the clinical cases. And here 4 incisors. Clinical forms: enamel discoloration, insufficient development of enamel, and complete absence of enamel. Clinical forms: enamel discoloration. It is clinical case here. Look, please. It's white spots. You can see white spots. Then influence insufficient development of enamel, wavy shape, point shape, furrowed shape, and erosive form. It is furrowed shape and erosive form. Look please on these defects. And remember about complete absence of enamel aplasia. Localization of the lesion of the crown indicated age in which an in-change violation has occurred and its size for the duration of the violation period. X-ray only erosive and furrowed forms of hyperplasia we can see. Next one, only erosive form. You can see the first molar. Then a morphological study of hypoplastic enamel. It is changed width and direction of enamel prisms output with the development of a pathology characteristic of hypoplasia. Not only the processes of mineralization are disturbed, but also in the first place processes of organizing protein structure of the tooth enamel. Prevention and treatment of dental caries with enamel hyperplasia in children. First, it is general remineralizing therapy that including the intake of calcium glycerophosphate for amounts at an age-specific dosage and bioactive substances from the age of 10 and multivitamins. Local mineralizing therapy, it is a daily application for phosphate-containing toothpaste, electrophoresis with 2.5% glycerophosphate solution calcium, and children over 10 years. Institute of Dentistry offers the following scheme of therapeutic and prevention actions for prevention and treatment of complication of enamel hyperplasia in children. They prescribe mineral and multivitamin preparation, for example, calcinova, and course months course it is one semi-annually. But of course, we should prescribe these vitamin complexes with pediatricians. Then, calcium phosphate containing preparation Remodent for once a year, and fluorine containing preparation, different varnishes, triple processing for once a year. Clinical stages treatment of caries in teeth with hyperplasia enamel. It is preparatory stages. Pathogenic local therapy aimed at enhancing the mineralizing processes in weakened tooth tissues, and different medication you can see. Then mechanical treatment of caries cavity. When processing caries cavity in teeth with enamel hyperplasia, a gentle preparation method is used. Then, using the delay and filling method, after partial or complete treatment, the bottom and walls of the caries cavity are covered with calcium hydroxide preparations, and filing processes and filling of the cavity in carried out after 1 month. Permanent filling, the main requirement in the prophylactic focus of the filling material. Composite filling material from the group composite filling material for the treatment of caries in teeth with hyperplasia enamel. It is advisable to use Decafil mineral, and it is used in combination with gentle self-edge adhesive system edge and prime. It is example, guys. You can use different composites. Then, self-edge adhesive systems. Please remember, because you will have some tests task. And when treating caries in teeth with reduced caries resistance, it is advisable to use self-etching adhesive systems with a reduced concentration of an etching agent capable of releasing fluoride into the surrounding tissues. And for example, H and prime 3 and 0, Admira bond, for example, prompt L prop, then prime and bond and T. It is examples of self-etch adhesive systems. Then tooth restoration using standard metal crowns. It is very important and popular method now, often as a result of an extensive caries process occurring against the background of hyperplasia of enamel. A significant part of the crown of the first permanent molar is destroyed and required restoration. But you can do in restoration not only first permanent molar but second. Stage 1. You should, before placing the crown on the molar, the shape of the tooth is restored using a hybrid glass enhancement, for example, or a Campamere. Then the crown is fixed to the tooth thanks to cervical edge. It's better to use glass enhancement such as Fuji, for example, for cementation of crown on teeth with hyperplasia of enamel. It can be Fuji Plus, it can be Latin cement. In clinical cases, please look, guys, teeth number 3, 6, and 4, 6 with enamel hyperplasia. They weren't restored with standard metal crowns. Look, please. Then stage 3. Dynamic observation of the conditions of the teeth after being carried out for the purpose of clinical and, of course, X-ray examination. Time of follow-up visits preferably every 6 months. Classification. Enamel hyperplasia found in 1.5% cases. Plots enamel hyperplasia reach 1-4 millimeters in size and have a rounded shape, smooth surface, localized mainly in the area of the neck of the tooth, on the junction of enamel and dentin, in the bifurcation of the roots or the roots themselves. And 5 types of enamel drops are morphologically distinguished. It is true enamel, enamel dentin with pulp, drops Rodriguez ponti, it is small enamel nodules at periodontium, and intradental included in dentin. So classification. Dental fluorosis, a special case of hyperplasia, is a violation of the formation of tooth tissues under the influence of excess fluoride intake. And dental fluorosis is an endemic disease that develops in children permanently living in regions with a high content of fluoride in drinking water. It is characterized by chalk-like stains, brownish coloring, and enamel destruction. About etiology and pathogenesis, dental fluorosis is a result of an excessive fluoride entering the child's body during the period of amelogenesis. Drinking water is the main source of fluoride for a human body. Remember that concentration in drinking water should be 1.5 milligram to liter, and optimal concentration is from 0.8 to 1.2 milligrams to liter. Higher concentration of fluoride, it is more than 2 milligrams to liter, in drinking water lead to increase of fluoride prevalence and the severity of its clinical courses. And classification, Miller classification. So, for example, light gray, it is light blue fluorescence of enamel, medium and severe degree. First degree, it is questionable fluorosis. It is scarcely noticeable white stains that become more noticeable after drying of the surface. Second degree, very mild fluorosis and opaque white stains covering less than 25% on the tooth surface. 3 degrees, it is a very mild fluorosis, opaque white stains covering less than 50% of the tooth surface. And 4th degree, moderate fluorosis, tooth surface is totally affected. Brown stains and abrasion of occlusal surfaces may be present. 5 degrees, severe fluorosis, tooth surface is totally affected. Large brown stains and enamel destruction are present. Spotted shape of fluorosis on the surface of enamel, there are white and brown spots. You can see it. The enamel is smooth and shiny, and the degree of damage to symmetrical teeth is approximately the same. And clinical forms, Schalk specklet form against the background of Schalke altered enamel. There are yellow-brown spots and pin point defects of enamel. Erosive form characterized by the presence of erosion, and destructive form characterized by the gradual destruction of tooth enamel and their abrasion. Erosive form, you can see it. Look, please. The enamel of the incisors is yellow-brown color. There are small areas where the enamel is absent. So it is in epidemiological studies. Differential diagnosis of fluorosis is made with enamel hyperplasia. Spotted form of enamel hyperplasia is the most difficult to differential diagnosis. In case of systemic hyperplasia is the most, as well as in case of fluorosis, deciduous teeth are rarely affected, and shalk-like stains in cases of both fluorosis and hyperplasia locate symmetrically on teeth in areas of dental crowns that are atypical for caries, for example, labial and lingual surfaces on cups and incisal edges. In case of fluorosis, the stains are pearl white, glossy, painless under the probe. They gradually transform into unchanged enamel. In case of hyperplasia, stains are white, dense, and glossy. They have accurate limits. In case of fluorosis, shark-like stains, fluorescence light blue. The same does the intact dental enamel. And classification. Tetracycline teeth. Damage to the hard tissues of the teeth resulting from the intake of the antibiotics by a pregnant woman or child in the first year of the life, and manifested by discoloration of yellow-brown tooth crowns. sorry guys for this slide. Non-carious lesions that occurred in the tooth before it erupted. Hereditary odontoplasias, imperfect amelogenesis, imperfect dentinogenesis, and hereditary violation of the structure of enamel, and it is syndrome of Stanton-Kept bone, and osteogenesis imperfecta. According to International Atlas page, you can see some cases, and you can see some cases from these literature books. Imperfect amelogenesis, smooth hyperplasia with autosomal dominant inheritance. Clinical signs: it is seen enamel. Enamel color from yellow to yellow and brown. Delay in eruption of permanent teeth is possible. X-ray signs: less enamel thickness. There can be obliteration of root canals due to dystrophic calcification of the pulp. And the teeth are yellowish. The enamel is smooth, shiny. There are no contact points. The tubercles of the molars are not pronounced due to the thinning of the enamel layer. Imperfect amelogenesis, clinical signs: enamel is almost completely absent. Erupted teeth are yellow or unpigmented. Dentin, the surface of the crown is round, granular, similar to frosted glass, and often delayed eruption of permanent teeth. X-ray signs: possible resorption of crowns of unerupted teeth inside a valley. And imperfect amelogenesis, you can see how it looks. It is teenager 16 years old, and enamel is almost completely absent. Dentin is very pigmented, and boy is 11 years old. The same patient, lower anterior and posterior teeth. The enamel on all teeth is completely absent, with the exception of a thin strip at the neck in some teeth. And the same patient, upper teeth. There is an incorrect position of the central and palatal inclination of the lateral incisors. And the enamels on the incisors is present only in the cervical region here. Then, temporary and permanent teeth are affected in hemizygous man. Yellow-brown, thin enamel, hard, smooth, shiny, although the surface of the enamel may be growth, granular, and pathological abrasion of tissue is expressed. And X-ray signs: strips of various lengths are projected of the crowns of the teeth, and wheels of unequal density. It is inheritance linked to the X chromosome in girl, and the color and general shape of the crowns of the teeth is not changed. However, pronounced longitudinal growth can be traced on the surface of the teeth. And point hyperplasia with autosomal dominant inheritance. Also, enamel of normal thickness on the surface of enamel more than on vestibular, and point defects located in row or columns, subsequently stained with food dyes. Multirational disorders. Matte white enamel on area from 1 and 3 to 1 and 8, cutting off showing the body surface of the tooth. The changed enamel is dense and pigmented. And permanent teeth are more often affected. Hypercalcification enamels. It develops when enamel mineralization is disturbed. It is usually characterized by normal enamel thickness, a change in gloss and color to dark yellow or brown, and uneven enamel, its low strength and frequent chipping. Look please on clinical case. The enamel on the frontal teeth is partially absent and pigmented dentin, you can see. And second case, a child 10 years old. The enamel on the lower teeth with whitish and brown spots and stripes. You can see stripes. Has a lifeless appearance, and the central incisors on the left is broken off on 1.5 the height of the crown, and lateral upper incisors are rotated around their axis. Then, normal structure and violation of structure of enamel, a change in the color of the crown. Restoration with developmental defects, deciduous molars of a patient with amelogenesis, disorders in the form of demineralization, and restored with the metal crowns. Then develops as a result of violation of dental formation at the stage of tissue differentiation. The predentin matrix is involved, resulting in the formation of amorphous and disorganized and a tubular dentin with a high content of organic matter. And dentin dysplasia is characterized by changes in the peripalpal dentin and root morphology. So first type, dentinogenesis imperfecta. So teeth, the color is more intense, whitery gray, and teeth are quickly worn out. Possible defeat by caries, and deciduous and permanent teeth are affected. Bulbous form of teeth. Here you can see watery brown colors and abrasion of the crowns of deciduous teeth, and the first permanent molars are less affected. X-ray signs: thinning of the cortical layer of the jaws, and coarse structure of the spongy substances, and slowly progressive obliteration of the root after eruption. We can see root canals. So the second type, enamel colors white or gray, amber, and purple blue. Teeth opalescent or shine through. It is syndrome of Stanton-Cap depot, and purple color of crown is rarely possible, while the custom pathological abrasion is not pronounced. Then short opinion-shaped crowns possible. The enamel has a tendency to cheapen 2-4 years after eruption, and temporary and permanent teeth are affected equally. A delay in the resorption of the root of deciduous teeth is possible. Please look on the color of these teeth. Permanent teeth have an opalescence amber appearance. Crown are significantly worn, brown dentinics exposed. Child 13 years and child 9 years old, and you can see purple color of the crowns. The enamel peels off quickly, leaving only isolated islands. Dentin has a brown color and characteristic transparency. If the pigmentation is not pronounced, the dentin takes on a translucent amber shade, and hard tooth tissue is quickly erased down to the gums. After the eruption of tooth, normal in size and shape, the enamel, which has a grayish color, is chipped off. At the same time, complaints of pain from exposure of various stimuli are not observed, since initially their coronal and root cavities are obliterated. Look, please, gray color, yes, gray and black color of the dentin, and we can see normal enamel only near the neck of the teeth. Look, please. Very hard syndrome. And X-ray signs, we can see roots of normal length and shape or with hypersegmentosis. Sometimes the root of the teeth are shortened. Of course, we can see reduced tooth cavities, narrow or obliterated canals. Often we can see foci of bone loss in the apex area roots, and we can see reducing the heat of the crowns of the teeth due to their rapid abrasion. And you can see panoramic X-ray. Patient 13 years old. All teeth are permanent. The lower second molar. Look, please. Lower second molar. Here. On the left, in the upper jaw. Sorry. Incisors are absent, and the root canals of all teeth are not traced. Around the roots of the first layer molars, there are extensive foci of enlightenment without clear boundaries, which may indicate granulated periodontitis. Crown of all teeth, with the exception of newly erupted second molars, are worn with sharp corners and concave cutting edges. And 9 years old girl, the lower anterior teeth, including the canines, the first molar on the right in the picture has already erupted, and the temporal molars are missing. The eruption of the lower premolars begins. Look, please, lower premolar, second premolars. Intraoral X-ray of permanent teeth and pulpal cavity are absent. We can see pulpal cavities and root canals. The shape of crowns is changed due to their abrasion. 3-type isolated hereditary form of line palisades dentin. It is rare and has a wide variety of descriptions and clinical signs. The crowns of teeth, especially permanent teeth, can be bell-shaped, multiple opening of the tooth cavity. There are similarities with first and second types of imperfect dentinogenesis, is closer to type. X-ray signs, we can see the radiopaque contour of the tooth and the enlightenment inside it are determined since the production of dentin ends after the formation of the outer covering layer. And deciduous molars of the patient with dentinogenesis imperfecta and restored with standard metal crowns. It's good method for treatment in these syndromes. Dentin dysplasia type 1, root dentin dysplasia. So Clinical signs. Crowns are not changed, sometimes slightly changed in color, and the roots of deciduous teeth can be so under development that this leads to their rapid loosening and loss. X-ray signs, we can see different changes, for example, on the development roots of teeth with pointed tops and decreased zones crowns. The edge of the forming crown of the border with the growth zone is defined as a straight line and not an arch as in healthy teeth. And panoramic X-ray, all teeth are permanent at different stages of eruption. The tops of the formed roots, often anterior teeth, are pointed. The root canals are almost not traced. The root of the premolars are not fully formed, and we can see grown zone does not communicate with the root canals. The cavities of teeth have an atypical shape. A panoramic X-ray of 14 years old child with dental dysplasia first type. All permanent teeth are present and including the rudiments of third molars. The lower second premolars is impacted due to the lack of space in the jaw. All roots except for the lower second premolars and all second molars are formed. The tops of the formed roots are pointed, and pulp cavities are not traced. And the third panoramic X-ray of 15 years old adolescents with dental dysplasia. It differs from the previous case in a greater degree of formation of the second molars and the absence of the canines on the right, retention due to dystopia of the canine and the left, and the rotation of the premolars of the left around its axis. Then, obliteration of dental cavities or an atypical shape of tooth cavity in the form of one or more arcuate cracks located perpendicular to the longitudinal axis of the tooth in the middle or the crown or in the cervical region. It is a typical shape of tooth cavity. X-ray signs, pseudotaurodontism, an excessively large distance from the occlusal surfaces in the molar crown to its bifurcation with an obliterated tooth crown cavity. Then often foci of rare function with district borders around the roots. The location of the tops of the interalveolar septa is significantly below the enamel cement junction, and osteosclerosis of the alveolar bone and skeletal anomalies are possible. Then a second type and clinical signs, so we can see discoloration of deciduous teeth. Teeth are amber, opalescent, permanent teeth are of normal color, brown coloration is not excluded. And X-ray size, permanent teeth may have dilated coronal cavities, and rarely can there be areas of enlargement at the tops of intact teeth, and cavities of deciduous teeth are often obliterated. With osteogenesis imperfected, teeth are usually small, bluish gray, sometimes yellow, and wear off quickly, and ectodermal dysplasia characterized by fragile enamel. With marble disease, the enamel is quite chalky color, is easy rushed and chipped off. Thanks for your attention. I wait for your synopsis. Have a good day. Goodbye.